We are live.
Hello, good evening. My name is Dr. Dhanashri Ratra. I am a senior vitreous surgeon from Shankar Nethralaya, Chennai. It's my pleasure to welcome you all to this evening's webinar organized by the All India Ophthalmological Society. This popular series of webinar focuses on practice-oriented issues, and today we are going to talk on a very common problem which most of the patients come to us with complaining of floaters. So this is the webinar is walk-in float patients with floaters and how do we triage and how do we manage. We have a galaxy of speakers and panelists with us. Let me introduce them. Can I share my screen? So welcome again to this webinar, walk-in patient with floaters, how to triage and how to manage. This webinar will be chaired by Dr. Samar Basak and Dr. Lingam Gopal. Dr. Samar Basak is the president of AIOS and a very prolific anti-segment surgeon. Dr. Lingam Gopal is a distinguished professor and researcher from Shankar Nethralaya, Chennai. It will be moderated by me along with Dr. Santosh Honavar, the Honorary General Secretary of AIOS, and Dr. Manoj Mathur, Honorary Treasurer of AIOS. We have an galaxy of expert panelists with us, starting from Dr. Anirudh Agarwal, a young and dynamic uveitis specialist from Cleveland Clinic, Abu Dhabi. Dr. Jyotirmay Bishwas, who is a well-known name in uveitis from Shankar Nethralaya, Chennai. Dr. Shashank Rai Gupta, who is a dynamic vitreoretinal surgeon from Delhi Eye Care, New Delhi. Dr. Vinod Agarwal, again a young dynamic vitreoretinal surgeon from RP Center, AIMS, Delhi. Dr. Vineet Ratra, who is a highly skilled and a high volume cataract surgeon from Shankar Nethralaya, Chennai. And Dr. V.R. Sarvanan, who is a very favorite VR surgeon of everybody from Arvind Eye Hospital, Coimbatore. And we will be joined by a galaxy of speakers, all of them very well experienced and an expert in the field. We have Dr. Vishnu Deepti, who is from Chroma Eye Hospital, Visakhapatnam. She has done her UVA fellowship from Shankar Nethralaya, Chennai. Dr. Rakshita Kene, who is currently doing her UVA fellowship from Shankar Nethralaya, Chennai. Dr. Gagan Bhatia was a very bold, dynamic, young vitreoretinal surgeon from Shroff Eye Center, New Delhi. Dr. Abhishek Kara, again a young, enthusiastic VR fellow from Shankar Nethralaya, Chennai. We have Dr. Ramesh Venkatesh, who is a prolific scholar and researcher and has published extensively on imaging. He is from Narayan Nethralaya, Bangalore. We have Dr. Ish Nigam, who is a senior vitreoretinal surgeon from Shankar Nethralaya, Kolkata. And last but not the least, we have the distinguished speaker, Professor Michael Stewart from Mayo Clinic, USA. This is the program that we are going to follow today. And we start with the speakers, followed by we have an interesting debate, followed by the talk by Professor Michael Stewart, followed by panel discussion. I request the audiences to give the questions in the chat box, and we'll take the questions later on in the panel discussion. So if I may ask the first person to start. So it's my, sorry.
Good evening, all.
So it's my pleasure to invite Dr. Vishnu Deepti to talk on floaters after cataract surgery. Yeah, go ahead, please.
Good evening, all. Thank you, Dhanashri ma'am and AIOS for this opportunity. I'll be presenting a case on floaters after cataract surgery. We have a 64-year-old male who came with blurred vision for distance for 2 years. He is diabetic and hypertensive for 20 years, but under control. The rest of the history is not contributory to the case. His BCVA is 6/9 parts and 6 in right eye and 6/12 parts and 6 in the left eye. Except for the nuclear sclerosis with PSCC, the rest anterior segment is all normal. He has mild NPDR with soft drusen in both the eyes. And he underwent an uneven surgery, which is phacoemulsification with IOL in the bag under local anesthesia. But 1 week post-surgery, he comes with a spider web-like thing moving in front of his eye. And this is a fundus photo of his left eye. And anterior to the disc, you have a black shadow-like thing, which is the PVD. And vessels are a bit dilated, and you have RPE changes. Otherwise, the rest of the peripheral retina examined with IVO is completely normal. We just reassured the patient and explained him red flags like sudden increase in floaters, flashes of light, or a drop in vision. We have particularly asked him to monitor each eye separately. And since floaters and PVD-induced issues are predominantly common in the first few months and the first 1 year after surgery, we have asked for a frequent monthly follow-up for the first 3 months and thereafter 3 monthly for the next 1 year. Coming to the discussion, if we can categorize floaters as primary and secondary, and the primary floaters post-cataract surgery, post-PVD is the most common cause. It can also happen due to vitreoretinal disorders like Stickler's, Wagner's, etc. And the secondary floaters are basically because of cells caused by inflammation or deposits like amyloid or bled due to vitreous hemorrhage or preretinal hemorrhage. And in some cases, iatrogenic like intravitreal injections. Usually the depot steroids like IVTA or Ozurdex sometimes can be perceived as a floater. Or the air bubble, which is introduced during the injection, is usually perceived as a floater post-procedure. And in post-cataract surgery, the risk for progression to complete PVD is 7-fold higher. And this is basically because of 2 reasons, mechanical and biochemical. The mechanical changes happen because of the shape change post-cataract surgery. Actually, the removal of the lens causes anterior movement of vitreous, and this anterior movement causes a dynamic antero-posterior traction, which induces a force at vitreous base and other vitreoretinal adhesions, and causes break in the posterior cortical vitreous. And through this break, we have liquefied vitreous entering the subhyaloid space. This loosens the already loosened adhesions because of the age between vitreous and ILM, thereby causing PVD. And the biochemical changes that happen post-cataract surgery are mostly because of the vitreous structural changes, as in the proteins in the vitreous, the hyaluronan, its distribution, viscosity, the size, their molecular weight entirely changes post-surgery. And apparently, the microscope also induces some reactive oxygen species introduced into the vitreous. And inflammation caused during and post-surgery also causes some abnormal protein deposit in vitreous. All these biochemical and mechanical changes put together might have accelerated the PVD in a 64-year-old man. Thank you.
Thank you, Vishnu Deepthi, for the excellent presentation. I think you have very elaborately you have enumerated all the causes of floaters following cataract surgery. But I would say this is like one of the very common problem. And we as retina surgeons we get a lot of patients who are referred following cataract surgery for the floaters. So I would like to ask Dr. Vineet Ratra, like how many percentage of patients who undergo cataract surgery in your practice, they come with this kind of complaints of floaters, and how is it, how do you practically manage them? Like Deepthi has enumerated all the causes that can lead to floaters, but how do you practically handle these patients?
Yes, so nearly around 15 to 20% of patients following cataract surgery would end up with having floaters in the post-operative period. This can vary from early to till 3 weeks or 4 weeks until we see them, because we generally review them again in around 6 months or so. So the treatment would actually depend on the cause. They are basically more, say, if a patient has more dense cataract or a near total cataract or a total cataract where you have a vitreous with which is turbid, uh, which has those vitreous floaters. It's more common there, and a few have that, you tell the patient that. If you can see a PVD before, you'll explain to the patient that the floaters would remain. If there is a new floater, like Dr. Deepti said, you would want to follow the patient up more closely because these PVDs can cause a retinal break. So most common in these patients is to reassure them in the beginning. If there is, and tell them that if you see a shower of black spots, red spots, any curtain rising, falling, multiple, a fall in vision, you need to come back sooner and show.
Do you think that these floaters are like more common if you have placed say these are high value premium IOLs like
Yeah,
multifocal
so
IOLs?
in patients whom we you in multifocal IOL patients, there is a decrease in contrast sensitivity. So in those patients, they see these floaters more. It affects their lives much more than patients whom you do just a monofocal or a monofocal plus IOL.
How do you manage Deepti when these patients come to you who have undergone an excellent cataract surgery? You know, you are very happy with the outcome, but the patient is not happy. You know, patient is complaining of floaters. So how do you handle such patients in your practice?
So you ask me.
No, I am this Deepti. I just
Sorry?
want to know how Deepti would address such a
Yeah.
scenario.
Fortunately, so far I haven't had such a scenario except for the reassurance. Thank God we didn't have to try any ETR or
So
oxyplasma. I have no idea.
the first is reassurance. First would always be reassurance. Tell them that yes, these floaters you're seeing well. So I tell them you're seeing well. That's why you're seeing more floaters. Your retina is good. There are no weak areas. You generally get an optos done or get one of my our vitreoretina colleagues to have a look at them too if they are also very uh, sensitive to it or very disturbed by it. So there are very, I think there was one high myo patient whom actually I had, who who had undergone a multifocal, he was one-eyed, had multifocal IOL elsewhere, and he was a high myope. He was actually a cricketer from one of the northern countries and northern states, and had actually gone blind in one eye because of glaucoma. So he had come to his with uncontrolled pressures in the good eye, and we did a trabeculectomy. And as we did a trabeculectomy, we finished the surgery. First post-op day, he was fine, but then you could see that there was a lot of vitreous, this turbid vitreous, which was there, and his vision fell. I mean, he said, "I'm not comfortable. I couldn't see." So following this patient was referred to, I think Dhanashri only saw this patient and managed this with a floaterectomy. And he now sends messages saying that you've changed my life. I'm able to drive. I'm able to work. He had stopped working, saying that I couldn't go to work. He was a medical representative up north.
I think the expectations of patients are very high after the cataract surgery, and if they have floaters, then they get quite disturbed by that. So maybe it needs to be handled with care. And I thank both of you for highlighting the points in this care. I would now like to invite the next speaker, that is Dr. Akshita Kene. She would be talking to us about floaters due to vitritis.
Good evening. Is my screen visible, ma'am?
Yes, yes, it is visible. Go ahead.
Thank you, Dhanashree ma'am, and thank you, Team AIOS, for this opportunity. So, I will be presenting a case called a twist in the tail of floaters. So, a 30-year-old male presented to us with complaint of floaters in his left eye for 3 months and painless blurring of vision in his left eye for 2 months. On examination, his best corrected visual acuity in both the eyes was 6.6 and 6. Anterior segment examination was also within normal limits. However, there were cells in both the eyes in his anterior vitreous phase. So on fundus examination, right eye had no media haze, disc and macula appeared to be normal, and there were no lesions in retina. However, in left eye, there was dense media haze, disc was hazily seen, and retinal details were also hazily seen. Optical coherence tomography in both the eyes showed normal foveal contour. So he was diagnosed as a case of left eye intermediate uveitis, and he was further investigated where tuberculin sensitivity test and interferon gamma release assay were negative, and serum angiotensin converting enzyme was also within normal limits. He was then treated with oral steroids and tablet mycophenolate mofetil for 2 months. So at 2 months follow-up, he still had persistence of floaters and blurring of vision. So here we decided to hike up his treatment to injection adalimumab 40 milligram bi-weekly subcutaneous. So at 4 months follow-up, he still had persistence of floaters and blurring of vision where his vision dropped to 6/12. However, on OCT, the foveal contour was maintained. Here we decided to do diagnostic and therapeutic vitrectomy for this patient, and vitreous sample was sent for further histopathology. So here it showed atypical round cell infiltrate with possibility of malignant round cell tumor. However, the immunohistochemistry was positive for markers like CD20, BCL2, PAX5, and MUM1. Thus, he was diagnosed as a case of primary vitreoretinal lymphoma. He further underwent whole body PET scan and MRI brain, which were within normal limits. So at his final visit, he again had dense vitreous opacities in his right eye, and left eye appeared to be normal. So he underwent vitrectomy in his right eye, where we found atypical cells which were positive for again CD20 and BCL2 markers. He also had MYD88 gene mutation. We then referred him for further management to oncologist. He was advised high dose of oral methotrexate, intravenous rituximab, and oral temozolomide. So to summarize, a young male who presented to us with complaint of floaters was treated as intermediate uveitis. He was not responding to anti-inflammatory treatment. He underwent diagnostic vitrectomy for search of the cause and was diagnosed as a case of primary vitreoretinal lymphoma with no systemic involvement. So the points to ponder, or what are the difficulties we face during diagnosing such cases? First of all, young age, where floaters is such a common complaint, when to suspect masquerade in such cases. The role of vitrectomy, does it hold therapeutic importance too, and when to stop immunosuppressants in such cases before doing vitrectomy? The difficulties we encounter in tissue diagnosis, need of expertise, and the time duration we have for transportation of this specimen, and how to treat such cases where it is just intraocular lymphoma with no systemic involvement. Thank you. Here, I hand over for further discussion to Dr. JB, sir.
Can you show the next slide?
Yes, sir.
So it's not the usual thing to have a young patient presenting with the floaters to have primary vitreoretinal lymphoma, that too also such a young age. So we consider the diagnosis of intermediate uveitis, which was rightly kept in this case, but he developed dense vitreous opacity in spite of treatment with immunosuppressive as well as later on biologic agents. And then that time we thought that is something wrong, and we decided to do a diagnostic and therapeutic vitrectomy. Vitreous sample was sent for a microscopic study, and we showed atypical round cells with necrotic background. When you see necrotic background in a cells, lymphoma is a strong possibility, because the lymphoma cells are friable, they get necrotic, and they produce the inflammation. That's what they cause a floater in the eye. And this case, the vitreous biopsy was done, and vitreous biopsy subsequently on immunohistochemistry with several markers was found to be B-cell lymphoma. CD20 is a marker for B-cell lymphoma, and CD3 is the T-cell marker. CD20 was positive in this case, and there was other MUM1, BCL6, PAX5, which indicates the differentiation of this lymphoma, and showed is a high-grade diffuse B-cell lymphoma. And the patient subsequently developed that same opacity in the right eye, which was not that much of vitreous. There was few vitreous cells were there and developed dense vitreous opacity. And this time with the diagnosis of vitreoretinal lymphoma, we did the vitreous vitrectomy, therapeutic vitrectomy, and we got the vitreous sample analyzed, and that too also showed atypical lymphoid cells and was positive for immunohistochemistry for malignant B-cell lymphoma, diffuse large B-cell lymphoma. So the patient requires chemotherapy, intravitreal injection, methotrexate or rituximab can be given, but this place being bilateral lesion and already vitrectomy done, vitreous cavity was clear, decided to do chemotherapy with the methotrexate, rituximab, and another agent called, I forgot the name, that agent has been given for this patient. Patient is admitted to get the chemotherapy done. So how do you handle that vitreous samples in such case of atypical? It should be, specimen should reach the pathology lab within half an hour, and because the cells are very friable and should be done cytosine spin specimen, cytospin study to see the cells, and astute clinical pathologists should be able to see that atypical large cells. And if you see the background of um, necrotic cells, you will see keep a strong suspicion of lymphoma. And nowadays, immunohistochemistry comes in aid to identify the lymphoma cell. There is also that gene study in MYD88L265 mutations, which you can do, which is positive in 70 to 80% cases. That to also confirm the diagnosis. One can do IL-10, IL-6 ratio also in such cases to rule out lymphoma. So when do you suspect lymphoma in an intermediate floaters in this case? If we see clearly, if you see in the slit lamp examinations and fundus examination, particularly slit lamp examination, anterior vitreous phase, the type of the cells which will be seen is the large. In the vitreous fibrils, this large coarse vitreous cells is located, and they call a sign called aurora borealis, and that would be keep suspicion of lymphoma. So it's not a very usual case. I've seen only 2 cases occurring in the 30 years younger people developing lymphoma. So the lesson is learned from this case is that all floaters are not benign, may not be intermediate uveitis. You should keep a close watch, particularly if it's not responding to your usual standard treatment of steroid, immunosuppressive agents, or even biologic agents.
That's a very good tips and an excellent message that you have given, that floaters, we have to be wary of all the floaters and not all are benign. And I would say we are very lucky to have you and Dr. LG and the entire expert UVA department to help us. But I want to ask Dr. Anirudh Agarwal that as a general ophthalmologist who is working like a solo practitioner who does not have support of this high tech lab and the high tech instruments, etc. How do you, what are the pointers where you would suspect that there is something wrong, and if you suspect a vitritis or a lymphoma, what are the initial steps that a general ophthalmologist should take?
So, good evening, ma'am. Thank you very much for the invitation. I think several important points were raised by Professor Biswas sir. I just like to say, when you are faced with a patient where you have a cataract preoperatively and the cataract is dense enough that it's very difficult to analyze the vitreous to look for vitritis, I think an ultrasound can give you a very good idea of pre-existing vitreous inflammation. And if you do notice vitreous inflammation, ideally, the case should be seen before cataract surgery by a uveitis specialist. So if you have the option of referring the patient to a uveitis specialist, please co-manage the patient because there may be an infective pathology such as toxoplasma lying behind. And so in such cases, it's better to have a full evaluation. Specifically in terms of lymphoma, in general, I would be very hesitant to perform cataract surgery in these patients. This is a very unusual case with a young patient with lymphoma. But in general, it's better to have a full examination. You can often look at the fundus lesions, yellowish lesions that are beautifully shown in the Optos figures in the slide before. If you have any yellow lesion on the retina, there is a sure shot sign that it could be an infective or non-infective retinal pathology for which you definitely need to rule out any sinister pathology at the back of the eye. So when in doubt, better to consult. Sometimes clinical examination alone is enough to tell you at least that there is something going on. And you can rely on basics like autofluorescence or even fluorescein angiography or at best an ultrasound in poor media to tell you the level of vitreous inflammation.
Thank you, Anirudh. That's very helpful. Sir, Dr. Lingam Gopal, I would like to ask your advice, sir. In this situation where you are suspecting some posterior segment pathology, would you advise to go ahead with just a cataract surgery, or would you advise to have a cataract surgery along with vitrectomy in such patients?
I think that would be a more individually tailored decision based upon what is the symptom with and sign with which the patient came to you. He has come to you with a dense cataract, you can't even visualize the vitreous properly. There's no way we can evaluate the retina, as was told by Dr. Anirudh. So, because of the lack of clear signs and symptoms, we are forced to remove the opacity in front so that you can get an access to the back of the eye. But as he said, an ultrasound, if you strongly suspect there's a lot of vitreous debris floating around, and you're not sure that you can exclude a major pathology in the back of the eye, then cataract surgery is just one step forwards in the sense on the table itself you evaluate after removing the cataract the back of the eye and see whether you can take a decision at that stage itself whether the vitreous biopsy is valid and required or not. The vitreous biopsy should not be taken lightly. If somebody has just a vitreous membranes due to say myopia or whatever it is and has no significant chance of having a vitreous lymphoma, doing a vitreous biopsy is probably not required at that stage. But then you're not able to judge beforehand because of cataract, as you wanted to give as an example. Then I would say do cataract surgery, examine the eye under the in the OOT itself under with data microscope. Take a call. Take the help of vitreoretinal surgeon or the oncologist at that time itself. But if in doubt, you can always close the case at that time and evaluate again a post-cataract surgery, and if necessary, always do a vitreous biopsy.
And I think it would.
Combining the two may or may not be required depending upon the individual case.
Thank you, sir. That is again helpful, and I think it would be better to plan cataract surgery with a full steroid cover in this situation. Yes, Aniruddha, please go ahead. Yeah,
I just like to make one more point.
yeah.
I'm more on the conservative side, and I would just like to get this message across that I would discourage cataract surgeons from going ahead with cataract surgery, especially if it's a bilateral disease and you don't know what's going on in the back. Sometimes cataract is the least of all the problems in the eye. And you often, the management of the cataract after you've done the surgery and the eye is pseudophakic is very difficult sometimes, especially in children with GIA, in patients who are uncontrolled. So if you have done a cataract surgery without the cover of steroids or biologics or immunosuppressants, sometimes it is extremely difficult for your uveitis colleague to then control the inflammation. So please be very sure and mindful that sometimes cataract is the least of the problems and it can be dealt with much later.
That's a very good point. Well taken, Anirudh. I think you have to be very careful in your evaluation, and as Dr. JB also mentioned, that not all floaters are innocuous, and you need to really have a good examination prior to going ahead with any kind of surgical management. So I think we can now go ahead with the next speaker, and I
Can
would
I
like,
ask a question, ma'am, from
sure,
Dr. JB, sir?
of course,
I'm
please
Vinod.
go ahead. Yes.
Sir, do you think there is any role of fluorescein angiography before we go in for a invasive test in the eye, for example, vitreous biopsy? Because it is often said that usually the signs of inflammations are not there in patients with masquerades in terms of vascular leakage and CME.
Fluorescent angiogram would not be much helpful with the kind of a media opacity present in this case. And but if the media opacity is less, you can do always a fluorescent angiogram. I'll do an OCT also. And OCT would be helpful to see that sub-RP lesion and pre-RP lesions in that one nodular infiltrate can be seen, and which may suggest the lymphoma.
Thank you.
Also, I think Dr. Ramesh wants to know whether it is possible to identify the cause of the floater from the examining the floaters itself. Is it possible to determine, Dr. JB and LG, sir?
I'm not sure. Amyloidosis is another condition which can produce the vitreous floaters, and there also the vitreous biopsy is going to be quite helpful. But they have amyloidosis has got a very characteristic sign like woolly strands like opacity in the vitreous, and they occur in the much more older age usually.
So, Professor Stewart, what is your experience? Do you think we can identify the causes of the floaters from examining the nature of the type of the floaters or the size of the floaters, etc.?
You are muted, sir. Dr.
You're
Steve,
muted.
you are muted.
I'm sorry. Yeah, we've not had good experience in trying to identify, based on slit lamp or fundoscopic examination, to look at the size, density of the floaters, etc. But we look at the entire patient, and I get my ocular oncologist involved. And so we determine what are the highest risks of disease in this patient, and then we'll taper, or we'll actually point the therapy or the diagnostics based on what we think. Certainly in those patients who were worried about vitreoretinal lymphoma because they don't seem to have much anterior inflammation, it's really more vitreous without the pain. We'll go ahead and do a diagnostic vitrectomy, and we'll do exactly as you said. We'll call the pathology lab in advance to make sure they know the specimens are coming so as to get it looked at very quickly. But at the slit lamp, fundoscopically, I'm not convinced that we can do it very well at this point.
Right. So I think a high index of suspicion is what is needed to identify the cause, if at all you are thinking of something. Okay, so I think we would go with the next speaker now, and I would like to invite Dr. Gagan Bhatia to present his case on floaters due to vitreous hemorrhage.
So good evening, everyone. Am I audible?
Yes, Gagan. Yes, go ahead.
Yeah. So thank you, Dr. Dhanashree, for this invitation, and to the AIOS committee. So floaters in vitreous hemorrhage, I think the pathomechanism for vitreous hemorrhage is bleeding from abnormal vessels. And then we have disruption of blood vessels, which can lead to a vitreous hemorrhage, and also breakthrough hemorrhage. So one of the most common causes is PVD, and I think we've been discussing this all through this meeting, and which is very imperative to know. The second is, could be with neovascularization such as PDR and RVOs. Then we also have situations such as RAM and angiomas, which could lead to vitreous hemorrhage. Could PHCR and AMD are one of the other causes that do lead to a breakthrough hemorrhage and could be one of the causes for a vitreous hemorrhage, and other conditions such as trauma. As far as age is concerned, children usually present with trauma. Young adults, again, eels and trauma are the common causes. In middle-aged people, we would identify, floaters with PDR, IPCV, or PVD, along with vitreous hemorrhage. And the elderly, the AMD is one of the common causes. As far as systemic history is concerned, I think diabetics and hypertensives are again the high-risk people. And as far as symptoms are concerned, usually they would be acute onset floaters, and also do present as shadows, cobwebs, or seeing a red hue as the screen goes red. So coming to a walk-in patient of with a vitreous hemorrhage floater. So if you have mild vitreous hemorrhage and the fundus is visible, it is suggestive that you look for the signs of, the underlying disease, which could be PDR, BRVO, HST, or AMD. If you suspect a PVD, scleral depression is a must, as 70% of chances of having an HST with the vitreous hemorrhage is possible. Other ancillary tests such as FFA and OCT also helps in confirming a diagnosis. And if in cases where there is absolutely no view, I think ultrasound helps a lot. So coming to some representative cases, I think this 56-year-old female, she came with floaters since 3 days, which were basically complained of red strings. And there was a suspicion of PVD. A good indirect picked up HST in the superior nasal quadrant. So at this stage, I think it's imperative that you go ahead with the laser. The patient needs to be counseled about that. Optos photos helps if you can show them the lesion. And then, so the prophylactic laser was done. The rest of the things about precautions of not lifting heavy weight, and also counseling them on the on the signs and symptoms of a retinal detachment is imperative. These patients need to be kept under follow-up because there are chances of further HSTs to happen. Anyways, the floater self-resolved, as the vitreous hemorrhage also resolved, and the patient was happy. This 80-year-old male came with again sudden acute onset of floaters since one day and drop in vision. Again, a good examination is important. Back in the days during training, I think vitreous floaters was meant to be something just seen on. I mean, vitreous hemorrhage was something which was supposed to be only studied on a B scan. But I think better indirect skills. I think you pick up this. You see a vitis subretinal lesion, suspicion of a subretinal. CNVM was there. The patient underwent a vitrectomy, and then we confirmed the diagnosis on an angiogram as well as on OCT. So this patient also improved, the floaters went away and is still on treatment. So this 58-year-old female came with again sudden onset of floaters in 3 days. She's a diabetic, never had a retinal examination done before. Vision was around 6/15, and you see this little clump of vitheme which was there. There was a slight suspicion of an NV in the nasal quadrant, and so we went ahead and did a sorry we went ahead and did a FFA to confirm the diagnosis and picked up the NVE. At this stage, I think the patient was counseled that you might need a surgery, but we went ahead with PRP. You could supplement this with an anti-VEGF injection, but be careful also to do a OCT because a taut hyaloid sometimes can lead to further bleeding. This next case was a very interesting case of a young female who presented with floater since 4 days, and she was diagnosed with vitreous hemorrhage. There was no detectable lesion on an indirect ophthalmoscopy, and so we went ahead and did an FFA. And on an FFA, again, the FFA was practically normal. Arm retina time was absolutely normal, though there was this very stipple kind of leak over the disc. And incidentally, during the FFA, we realized that she had a very high BP, and she was basically then just under observation, and the floaters reduced with time along with BP monitoring and BP treatment. This case of a 76-year-old female, again presented with floater since a week. On indirect, we saw this very well-defined hemorrhage, which was a boat-shaped hemorrhage, which was over the major arcade vessels. We suspected a RAM because she was a known hypertensive. These images were again taken through the heme itself, and the diagnosis of RAM was confirmed on OCT as well as a high flow lesion on an octa, and the patient was again managed with just anti-VEGF injections and is doing well. This case is of 66-year-old female, again present diabetic, hypertensive, never had a retina checkup before, came with floaters of 3 days and a drop in vision. There was no view of the fundus, so B scan basically showed a vitheme with a subhyaloid hemorrhage. There was no obvious retinal detachment or any retinal lesion that was picked up. The patient came back after 5 days with a visual acuity, improved visual acuity, and on indirect we saw these sclerosed blood vessels. And what was surprising to see was that there was a retinal break, an HST, along with an FEP at the superior arcade. And the patient was advised surgery, but was not systemically fine at that time. So just to protect the macula, we went ahead and did a laser barrage through that vitheme. And after systemic clearance, the patient was taken up for surgery, and surprisingly, the vision improved to 6/9 and 6 in spite of that vascular supply to the macula. So these representative cases basically tells us that floaters due to vitreous hemorrhage always do a thorough indirect, and it's not just left to a B scan. Look for clues of the underlying pathology. That's very important. And if you suspect a PVD, it is imperative. Most of the cases, if you have a vitreous floater or a vitreous floater vitheme, there would be an HST somewhere. So do a very good indirect. Multimodal imaging can be used wherever possible, and early intervention in cases with no view and no past history of underlying disease is imperative. So if you see these squiggly lines, I think on the screen, it is just empathy for these patients who see these floaters. Thank you.
Thank you very much, Gagan. That was really extensively. You covered all the scenarios and all the possible situations where a patient may have floaters because of vitreous hemorrhage. So, if you have a massive vitreous hemorrhage, that is fine. But many times, patients come with a little vitreous hemorrhage or some pre-retinal hemorrhage and some kind of floaters. So, these are the cases where, as you have correctly shown, that there is a role of fluorescein angiography in such a situation. So I would like to ask, Dr. Vinod and Dr. Sarvanan, they have many fellows and residents, training under them. So how would you, advise young specialists in solo practice? How would they go about when they see a situation where there is some vitreous hemorrhage or some pre-retinal hemorrhage, and you apparently see no cause for such a bleeding or such floaters? So what would you advise them to do in such situation?
So, first is that like most of these times in these patients with considerable floaters is the last complaint they come with. They come up with more often that visual loss is the main complaint. If the media is clear, proper fundus examination, if possible OCT or FFA. The media is not clear, then you have to go with the ultrasound. And depending on what you assume is the cause from the clinical findings as well as systemic factors, you may decide what you want to do. Like suppose that known diabetic, chronic diabetic with vitreous hemorrhage and no RD and ultrasound, I would prefer to wait and watch and then decide whether to do injection, surgery, or laser, depending on what happens. Like in other cases, if there's subretinal hemorrhage, then we assume it is because of PCV or a PHCR, then you want to give intraretinal anti-VEGF. But if the cost is not clear and the retina is still attached, I would usually consider waiting for at least 2-3 weeks. And if it's not resolving, you go ahead with the vitrectomy surgery and try to assess what is the cause and treat them. So, but what I feel is in these cases, most of the time, the floaters is not the main issue, but the vision loss is the main issue. And you have to try to address understand what is the pathology and try to address that. That's what I'll try to comment to my fellows and juniors.
I think one very important thing is that, as Gagan rightly highlighted, that most of these patients, the floater is a symptom of a disease, underlying disease. And a good history taking and examination would clinch the diagnosis in most of these patients, especially if we have some clarity of media. Now, once we have the underlying diagnosis, we treat the patient according to that. For example, Gagan showed a patient where there was a tear and then found a tear and then we lasered it. But one thing all fellows and practitioners should be aware that we are doing laser here for the treatment of the underlying cause. It is not going to affect the floaters. So many a times patients think that our floaters are going to get okay with this laser or the underlying treatment. So we need to explain to the patient that floaters are the symptom of a disease and we are treating the underlying cause. While we are doing surgery, it may clear the vitreous cavity and lead to removal of floaters. But most other scenarios where the hemorrhage is resolving on its own, it will take some time for the floaters to go away. So that is something which we should very clearly mention to the patient so that the patients know what to expect after they undergo treatment for the primary underlying disease.
Yeah, very nice. And there is actually one more very common scenario where patient has had full PRP where the retina is all well blasted, but then he comes with some recurrent hemorrhage and they complain of some floaters. So I would like to ask Sir Dr. Lingam Gopal sir, what is your advice in this situation? I mean, is it that you just go ahead with anti-VEGF, or would you like to do some further PRP or anything else? What would you suggest, sir?
I'm sorry, I missed your question. Can you repeat the question?
Sir, there are situations where patient has had a full PRP, pan-retinal photocoagulation is done, but they still come with some recurrent bleeding, some here and there, some patches are bleeding are there, and they complain of floaters. So I find that these situations are very common, especially in young diabetics. So there is no space to do further laser, but still patient has active bleeding. So what is your...
I think beyond a point, more laser is not going to cure the problem, because some of the bleeds which occur after adequate laser is because of physical pull on the new vessel, which keeps happening because the vitreous is not totally separated from the retina. As long as the bleeds are small and not affecting the daily function of the patient, we just leave it, let it go. Even anti-VEGF is not going to cure that, because that's basically caused by vitreous traction. We already lasered well, there's not much of VEGF being formed in the vitreous cavity, but the physical pull of the vitreous can cause repeated bleeds. I guess again, this is an individual patient-based decision where adequacy of laser cannot be defined, and most people don't believe that you should totally destroy the entire retina unless it's really showing a lot of VEGF being secreted and VGS occurred, etc. The routine diabetic patient, there's no meaning in keeping on doing laser just because each time he comes with a small bleed.
Sir, I think your voice is not coming very well. It is coming very faintly. So
You
maybe
could not hear what I said?
yeah, now it is better. Yeah. No, we could hear, but it was very faint. So
I'm sorry.
yeah. But anyway, thank you so much. It is definitely your advice is well taken. I think people must take care of the vitreous traction and look at the source of bleeding from where it is coming. I find that in very few situations, very select situations, you can give anti-VEGF agents in situations where they're just to control this kind of excess bleeding which occurs. But again, it has to be decided by case to case basis. And one more thing I would like to ask, we are of course going to listen to the debate later on, but I would like to ask Dr. Ish Nigam, in situations where patient has come with some bleeding and despite your efforts you are not able to see any break or anything, how would you advise for the surgeon, how would you advise the ophthalmologist to go ahead? What should be done in this situation where you have done an indirect ophthalmoscopy but you still can't find any break?
Good evening, everybody, and thanks, madam, for this opportunity. First of all, the patient should be asked and assured that he needs a quite close follow-up for this condition. And then whenever the media gets clear or the things come up, sometimes the evolving PVD and the later on the breaks emerges, then we have to timely treat the condition accordingly. That understanding the patient if has, and then he comes for a follow-up, then the compliance of the patient also gets better if the patient understands the things.
Yeah, better not to just send away the patient if you don't find any break. You need to keep a close follow-ups, and it is little dangerous to just send him away and say, okay, you are fine and go away. So I think that is what the message that the young ophthalmologist should carry, that not to just neglect it and call the patient back again for another checkup, or you ask your colleague to have a look and see whether they can find anything, but not to leave this patient.
Okay, can I make a statement, Dr.
Sorry, sir.
Can I make a statement?
Yes, sir. Yes, sir. Of course, yes.
No, I thought in the past, patients coming with vitreous hemorrhage with no identifiable breaks, although the hemorrhage is significant, we were observing and then waiting for the blood to clear. In the era of the 25 gauge vitrectomy, there is really no need to wait for too long and miss an opportunity to treat it as a retinal break and avoid it from developing into detachment. So I think if we wait for a reasonable period of time and the media is not cleared enough for you to be able to judge at least 80% or more the retina clearly, it's time for us to go in and clear the hemorrhage, make sure that we have the risk of break and treat it.
Thank you, sir. That is a very good advice. So I would now like to call upon the next speaker, Dr. Abhishek Kara. He would like to talk about vitreous floaters due to visual snow syndrome. Abhishek, you are muted.
Hello. Yes. Am I audible?
Yes, you are audible now, but your presentation.
Can you see now, ma'am?
Yes, yes. Go ahead.
Good evening, everyone. I'd like to thank Dr. Dhanashree ma'am and the AIOS for this opportunity. Today, I'll be presenting a case on a rare cause or a less identified cause of visual floaters, that is the visual snow syndrome. So I'll be presenting a case of a 36-year-old female who was a pediatrician by profession. She presented to us the emergency with the complaints of increase in the floaters in both the eyes. There was no associated flashes of light or diminution of vision along with the floaters. So on further questioning, she complained of seeing rain-like floaters all the time, in the day as well as night. The floaters, they persisted even with her eyes closed. On further questioning, she had a history of after images, which is known as pelinopsia, and also gave a history of tinnitus. In negative history, we asked for she had no history of photophobia, no history of difficulty with the night vision, no history of anxiety, and no history of any recreational drug use. On further examination, her bus-corrected visual acuity in both the eyes was 6.6 and 6, and IOP was within normal limits in both the eyes. The anterior and the posterior segment examination was unremarkable. No peripheral treatable lesions were noted in both the eyes. This is showing the front optos image of both the eyes. We can see the media is clear, the disc and vessels are healthy, and no peripheral treatable lesions were noted in both the eyes, which would account for the floaters. In past history, she had a history of COVID infection twice, after which, after the second infection, she had an episode of migraine with aura, and there was associated tongue numbness and left-sided paresthesia. She had no other systemic illness along with it. She was extensively investigated by the physician as well as the neurologist. The coagulation profile, homocysteine levels, vitamin MRI brain, as well as an MR angiography had been performed, which was within normal limits. And also the vasculitis workup was done, which was within normal limits. She was already taking tablet Ecosprin for the prophylaxis following COVID. So we referred her to a neurologist and she underwent the complete examination. No neurological abnormality was detected. As the ophthalmological as well as the neurological examination was within normal limits. So she was, as it is a diagnosis of exclusion, so she was diagnosed as a case of visual snow syndrome and was advised for some tinted glasses to reduce the visual symptoms. So coming on to the discussion, the main clinical feature in visual snow syndrome is the unlimiting positive visual phenomena which are present in the entire visual field. They are continuous and without any period of remission. Unlike the visual disturbance which we see in the migraine, which is episodic. It is characterized by uncountable tiny flickering dots which are present between the person's vision and the background. Some additional symptoms are usually present in patients with visual snow syndrome. The most commonly encountered are palinopsia, that is after images, atopic phenomena, which can be floaters and multiple colored images, which the patient can be seeing, photophobia and nyctalopia. The patients, they experience different combination of these symptoms. A combination of at least 3 of them is present in most of the symptoms. So these are a few representative images that we have created. So this is showing a black and white rain-like dots which the patient is able to see in the entire visual field. This patient is showing the palinopsia or the after images. This image shows the positive atopic phenomena which can have floaters-like things, and the floaters can also be colored or they can be black and white in the visual snow syndrome. Or sometimes the patient can have a combination of all of these floaters and as well as after images. So as we can see, this can be very visually debilitating for the patient. So a patient who is presenting with a floater should not just be brushed aside if we cannot see the cause of the floaters. Should be further investigated and further history about the type of the floaters and also the associated symptoms should be taken. Thank you.
Thank you, Abhishek, for that excellent presentation. And so actually this was my patient only. I had only seen this patient in the OPD. And so when I actually saw this patient, I was not aware of this visual snow syndrome. And this is actually a new entity which is very recently has come to light. And as late as 2014, it was named as visual snow syndrome. And I saw that it was first reported in about 1995 or 96, like that. So it is a very intriguing phenomena, and it's a very much disturbing for the patient and as well as for the ophthalmologist. I don't think many of us are not even aware of this syndrome. But the patients, they complain of these peculiar floaters, which is this person who came. She was a pediatrician herself, and she very clearly described her floaters, that it was like rain falling all the time. So and then I read up about this visual snow syndrome, and actually thereafter I have seen nearly 5 patients who had this visual snow syndrome. So it may not be as uncommon as we might think. And only problem is that these symptoms are not taken seriously by people, and some of these patients are actually they are undergoing psychiatric treatment, thinking that it is probably some psychological problems that they are facing. So I just wanted to through this discussion make people aware that there is an entity called this visual snow syndrome, and maybe we can discuss a bit about that. So maybe I would like to ask the panelists whether they have any experience of diagnosing and treating this visual snow syndrome.
Just one point I would like to make is that
Yes, sir.
it's not always benign as it is thought to be.
Yes.
Sometimes there can be a brain tumor, something located near the occipital cortex, which can produce visual snow syndrome. So as a routine, everyone should undergo an MRI first. And only when MRI is normal, we declare them as benign and then treat according to the severity of the symptoms with the help of a neurologist.
Yes, sir. Very rightly, sir. Sometimes even epilepsy can be associated with these positive visual phenomena, and so you must rule out primary neurological pathology before you can label this as a visual snow syndrome.
I think it's important to remember this is a diagnosis of exclusion, and we need to listen to patients very carefully. And when we find the symptoms just don't fit with floaters, they don't move around, they don't change with eye movement, they're fairly constant, and they're usually bilateral, then we need to consider visual snow. And in our case, we send the patient to our neuro-ophthalmologists, and they go through the workup, and then because they're very familiar with this phenomenon, and when they come back with a diagnosis of visual snow, usually the diagnosis and the understanding of the patient is sufficient to really alleviate most of their symptoms, because most of them are worried that they don't have a diagnosis and they're worried about the possibilities of what could be. And when they finally understand what it is, they become much more functional and with far fewer anxiety related problems related to this.
Yeah, that's
Dr.
very well
Dwivedi, can
said.
I make a small comment?
Yeah. Yes, please go ahead, Ramesh.
So, these visual palinopsias, they can happen with certain drugs as well, especially if you have a female who's on clomiphene citrate or ovulation induction drugs. They actually can present with visual hallucinations and palinopsias as well. And actually, we published a couple of cases of visual palinopsias and with clomiphene citrate. So even that was initially what I was saying when I was looking at your case, whether this patient was on any ovulation induction drugs. So if you don't identify any of those causes, then the visual snow syndrome could be considered, like what Dr. Stewart said, it would be a diagnosis of exclusion.
Yeah, very
Thank you,
right.
ma'am.
There are some drugs such as these hallucinogenic drugs which can cause these kind of symptoms. These are positive phenomena, positive visual phenomena. But this particular patient was not on any clomiphene. She already had two kids, so she was not on any infertility treatment. The only thing we could find was that she had COVID, and she very clearly said that after the COVID second attack of COVID, she developed this within a few days. So there are some situations where you have a inciting factor. Most of the visual snow patients, they develop it spontaneously, but some patients may have an inciting factor. So probably this COVID could have acted as an inciting factor in her case, and some other sometimes it can follow a trauma, or some fever also has been reported where it can act as an inciting factor and patient can develop this visual snow.
I also have seen one patient with not like flashes, but this blurring and double triple imaging, and a patient was undergoing treatment for PCOD. So then we are not sure what was happening, and when once we stopped the drug, she recovered. And most of the times, what we see in very anxious people is not the visual snow syndrome, but the even the mere presence of the entoptic on awareness of the white blood cells in this network. The very anxious people, they get super anxious, and then once we explain that what's causing this, they tend to understand and take it in their own stride. But sometimes it's very difficult to convince patients that everything is normal with them, nothing to worry about, and they are really totally anxious. It takes multiple sittings, and they sometimes keep hopping between hospitals and hospitals to finally diagnose and we understand what's really going on.
Yeah, true. As Dr. Professor Stewart also mentioned, and as you are also saying, I think it's most important that the patients understand the cause of their problem, because basically this visual snow is a benign condition and it is a non-progressive condition. So it's not necessarily that the patient will worsen. If the patient accepts the symptoms, some of them can get relieved after some time. And I'm not very sure about the treatment which is available in India. But do you do any treatment for these patients, Professor Stewart?
You are muted, Dr. Stewart.
I'm sorry, that's three times. No, we don't. Once we've ruled out any secondary causes, then it's counseling by the neuro-ophthalmologist, and that's usually sufficient.
So I was just reading up on this, and I saw that some of them are treated with as simple as acetazolamide, and some of them are treated with this verapamil and anticonvulsant drugs, and some lamotrigine has been advised for some patients, and they have seen that some patients they get relief of symptoms with this. In our institute, we have given them these filters the yellow filter and the brown filter, and some of them they felt better with these filters. So I guess we can try these kind of non-invasive treatments for that. Very good, sir. LG sir, any final comment from your side?
No, it's just that it would depend upon the severity of the symptom and how much the patient is distressed by the symptoms. As Professor Stewart said, mostly once you explain to them the nature of the problem and it's benign, they tend to accept it and they probably live with it without too much of a problem. There are a few who are really, really bothered. That is where probably you give anticonvulsants and all that. Those are not necessarily drugs we routinely prescribe for this kind of condition. But if they're just, they accept it, they want to live more comfortably, filtered gases would help.
Thank you, sir. That brings us to the exciting part of this webinar, and the next two talks will be about like some sort of a debate. So the first one is by Dr. Ramesh Venkatesh. So I will, he's there, but I will play his video. And this is about whether wide field imaging is enough to do screening for floaters. So I will just share my screen, and Ramesh, I would request you to be there for discussion.
Sure, ma'am.
Good evening, everyone. At the outset, I want to thank Dr. Dhanashree and the AIOS team for allowing me to be a part of this interesting webinar on floaters and the screening of it. I'll be presenting the first half of the debate on whether the wide field imaging is an efficient tool in screening cases of floaters. Now, let's understand why this debate is important. And we know that the floaters, they form a most important component or the most important complaint of the patients in the retina clinic. And as retina specialists, our aim is to identify those sight-threatening cases of retinal detachments, retinal tears, and vitreous hemorrhages, which require immediate attention. The traditional way of identifying the floaters previously was to look at the dilated fundus examination with indirect ophthalmoscopy. And at the same time, with the advancements in the retinal imaging, a question which we need to ask is that do we really need to do dilated fundus examination in every patient who is complaining of floaters? So in this debate, I will provide you evidence why the wide field imaging is an efficient first-line screening tool in the management and in the diagnosis of floaters of patients presenting with floaters to the retina clinic. Before we enter into this debate and understand the effectiveness of wide field imaging, let's understand what is wide field imaging. The traditional true color fundus camera, it provides you a field of view around 30 to 50 degrees with the Topcon TRC 50DX machine. But when you look at the recent advances in the retinal imaging system, you have an image which is as large as 200 degrees, which is obtained with the Optos Daytona machine. And with this single capture image, you can see as much as anterior to the equator in a single image itself. Now, with the wide field imaging, it captures around 200 degrees of the retina in a single image compared to the 30 to 50 degrees which you get with the conventional fundus photography. The common platforms where you can get this wide field imaging is with the Optos machine, the Zeiss, Claris, and the Nidac Mirante machine, which we have in our organization. And these systems, they basically use the CSLO laser scanning technology, which can provide you a detailed view of the retina in a non-mydriatic, non-contact fashion. This is a 63-degree view of the Mirante Nidac camera, which is available. Now let's understand how effective the wide field imaging is in detecting the retinal pathologies in symptomatic patients with floaters. And let's look into the previous studies which have evaluated the symptomatic patients with floaters and the role of wide field imaging in these patients. Aravla et al. Detected around 92% of the retinal tears and 94% of the retinal detachments with wide field imaging, and they concluded that it is an highly sensitive tool for detecting these sight-threatening conditions. While Nicholson et al., they studied more than 500 patients of symptomatic patients and found that only 3% of the patients with clinically significant pathologies were missed by the wide field imaging. Silva et al. In 2017 reported that the teleophthalmology using the wide field imaging reduced the need for in-person dilatation by around 60% without compromising on the patient safety. Let's look at further studies. Now, Patel et al. In 2021 concluded that the wide field imaging detected 95% of the peripheral tears with a high degree of inter-observer agreement. The wide field imaging also, when combined with artificial intelligence, reduced the unnecessary need for dilated fundus examination in 70% of the cases without missing pathologies. While Rosen et al. In 2019 evaluated a cohort of around 800 symptomatic floater patients and noted that only 2% of these cases of the pathologies which require treatment were missed by the wide field imaging. So to conclude, we can say that the wide field imaging is a highly effective as a first-line screening tool for patients presenting with floaters. Now let's understand the advantages of the wide field imaging over the traditional fundus examination. And we know that from this table that when you look at the different aspects of examination itself, we know that the field of view which the dilated fundus examination can provide you is much better, up to 360 degrees, but that comes only with scleral indentation and a full dilatation and full pupillary dilatation. The time required for an efficient screening with a dilated fundus examination is much longer, up to 10 to 15 minutes, whereas with the wide field imaging, the acquisition time is only around 2 to 3 minutes. The patient comfort is also much better with the wide field imaging because of the non-contact technology and the non-mediatic way of looking at the retinal image, whereas it's very uncomfortable for the patients, especially when you are doing or performing a scleral indentation with the dilated fundus examination. The wide field imaging, the images can be acquired by technicians. They are usually done by technicians, whereas the dilated fundus examination has to be performed by the retina specialist. And even the reporting of those images and the examination of those images can be done by retina and non-retina specialists with the wide field imaging, whereas you require a trained retina specialist who has got an understanding of the dilated fundus examination to be done for the DFE. The documentation in this age of medical legal problems, documentation is very important, and wide field imaging provides you that permanent image record, whereas no such image record can be obtained with the dilated fundus examination. And finally, and the most important from the doctor's point of view, is the ergonomics, where you don't have to bend your back or you have to bend your neck to evaluate each and every patient with the indirect ophthalmoscope. So overall, wide field imaging provides a faster screening, a permanent documentation, and a more comfortable patient experience while reducing unnecessary dilatations without sacrificing the diagnostic accuracy. Now let's understand why assessment of floaters is very, very important, because floaters, they can cause some vision-threatening complications such as the development of retinal detachments, the vitreous hemorrhage, and even masquerading conditions like vitreoretinal lymphomas, intermediate uveitis. So, but all this comes only in patients with high-risk cases, and those high-risk situations are patients with myopia, patient who had a history of recent onset trauma, and patient who had a systemic illness or infectious disease like tuberculosis and sarcoid, and even with masquerading conditions like vitreoretinal lymphomas. So when is wide field imaging enough for screening the floaters? So there are some situations where you can ask the patient only to get a wide field imaging, and these are routine cases of posterior vitreous detachment without high risk features like myopia, trauma, or associated retinal pathologies, where the patient does not complain of any flashes or curtain-like vision loss, where we call it as the floater plus features. The clear media, where you don't have any dense vitreous hemorrhage or media opacities like cataract, and there is no history of trauma, myopia, or other retinal pathologies. Now let's look at the most common clinical situations which we encounter in our clinic. So this is a 60-year-old male who presents with ring-like floaters since the last 2 years. In these patients, you can only do the wide field imaging, check for the PVD and any associated retinal breaks. If there are none, then there is no need for doing a dilated fundus examination. However, a patient, 60-year-old patient who has recently undergone a cataract surgery, presenting with an acute onset floaters over the last 3 days, can also undergo wide field imaging, and only if there is any presence of retinal breaks, then the dilated fundus examination can be considered. However, a patient who is having ring-like floaters for the past 3 days presents with an associated flash or a curtain-like vision loss. In those high-risk cases, the dilated fundus examination should be directly considered. Now, when is the wide field imaging not enough. So there are some times where you know that the wide field imaging may not give you the true picture, and these are the situations where you have the suspected inferior retinal tears or small peripheral breaks which can be easily missed because of the presence of the eyelashes which you get with the wide field imaging. The wide field imaging does not provide you with a stereoscopic view, so the tractional elements on the retinal breaks or the suspicious vitreoretinal lesions, they can be underestimated. They are in presence of severe vitreous hemorrhage or media opacities. The wide field imaging obscures the details, and in the extreme periphery beyond 200 degrees, the lesions may be missed. So with such a high effectiveness of wide field imaging, where you can actually identify more than 90% of the clinically relevant pathologies, do we really need to dilate every eye of the patient? That is the question which we need to ask. And the answer is an absolute no. The solution is a triage approach, which we follow in Narayan Netralaya, where we have a triage floater screening approach. And let me share that approach with you, where a patient with floater who has doesn't have any high risk situations like myopia, trauma, or any associated retinal pathologies, he directly undergoes a wide field imaging. If the image is normal, then there is no need for further dilated fundus examination. But if he shows suspicious lesions, then he undergoes a dilated fundus examination. However, a patient with floater having high risk situations like myopia, trauma, or any other retinal pathology, pre-existing retinal pathologies, will directly undergo for a dilated fundus examination. And the impact which it has created by this screening approach, it has reduced our unnecessary dilatation in more than 60% of the cases. It has improved the efficiency in the busy clinics, and it provides a better patient comfort without missing on the sight-threatening pathologies. So to summarize, I can say that the wide field imaging is an excellent first-line screening tool for floaters. It has a high sensitivity for detecting retinal tears and retinal detachments. It improves the efficiency, patient comfort, and the documentation. But cases with high risk situations, they still require the traditional dilated fundus examination with indirect ophthalmoscopy. So let's challenge the conventional approach and adopt an evidence-based practical screening strategy which benefits everyone, including the patient, doctor, and the organization. Thank you very much.
Thank you, Ramesh. That was an excellent presentation, and you have already enumerated all the pros and cons of wide field imaging. Dr. Ramesh has a flight to catch, so I would actually like to have the second presentation also, but because of your, the flight time, I will ask Ramesh to please go ahead and discuss about his presentation and give us the pointers. Or are there any some absolute must conditions where you will not rely on wide field imaging, but do dilated fundus examination?
So, like I said, ma'am, very specific. We call it as a. I don't know whether you are able to hear me or there is a disturbance as well. Can you hear me?
Yeah, we can hear you now. There's some. Go ahead, Ramesh.
Yeah, so basically we look at those floater plus symptoms, and when we say floater plus symptoms, we look at those cases where the patient is presenting with an additional flashes, where there is a vision loss, where there is a curtain-like field effect, where we know that the floaters are not responding to certain medications or steroids for a very long time. And in those cases, or where you know that there is a pre-existing retinal pathology, in those cases, we directly ask for a dilated fundus examination. Otherwise, most of the patients, about 7 to 8 of the 10 patients which come with floaters, we end up doing a wide field imaging, and that probably is sufficient to see whether what is the exact cause for that floater. So it helps. Wide field imaging actually helps us in reducing the the unnecessary dilatation, especially patients who have allergic to pupillary dilating drops or the mydriatic drops. I think these cases the wide field imaging is definitely useful.
Yeah, excellent, excellent, Ramesh. So maybe we'll just take one comment before we go to the next talk. And Ramesh, if you are getting late for your flight, maybe you can go ahead with your board your flight.
I'm actually inside the flight only, ma'am.
Oh, okay. Thank you so much for taking the time out for this presentation. I really appreciate it.
Can I make a point, ma'am?
Sorry?
Can I make a
would like
point?
to ask Ramesh a
Sure,
question
sure.
if you allow me.
Yeah, yes. Please go ahead. Dr. Vinod and Dr. Shashank, both of you can please give a comment.
Ramesh, if you are having a floater, would you like to get yourself imaged by WFI or would you like a doctor to give a dilated examination? And in continuation, would you like to go to a doctor who is ready to bend a back to check you, or you just want to go to a doctor who looks at the ergonomics?
Okay, so I'll answer this. Dr. Shashank, I already have floaters because I'm a high myo. Okay, but I always get a wide field imaging then because I feel it more comfortable. We always get an Optus then every 6 months. I just want to see if everything is okay or not. If I know if I know previously that I don't have any pathologies, then probably I will always go for a wide field imaging. It's very useful. It's very fast. It's comfortable. That's why I would like to do that.
Dr. Vinod.
I think Ramesh highlighted the things and studies very well. I think in a given patient, when the patient comes with specific history of floaters, by and large history of the patient, and by the complaints of the patient, and the age group of the patient, you can narrow down your diagnosis to a particular group of disorders, and that can guide you whether you want to dilate. We know that any floaters which have been there for 2 to 3 months, more than 2 to 3 months, which are static, which are not probably progressive, may not need a dilated fundus examination. But I will stress on the fact that if we are planning to do a optos, specifically for screening of the periphery, it is imperative that we do the steered examinations as well, because 200 examination degree of retina may not be sufficient. It's imperative that we ask the patient to look in all the directions and ask our technician to take photographs in all the gazes, so that we can increase the efficiency of wide field imaging as well. But any given day, I think 100%, to be 100% sure, as Dr. Ramesh also highlighted, we need to ultimately resort to dilated fundus examination.
Excellent. I think maybe we'll hear the second part of this debate also and then carry forward with this discussion again. So I would like to now invite Dr. Ish Nigam, who will give us the second part of this debate. So for screening for floaters, indirect ophthalmoscopy with a dilated pupil is a must.
Yeah, good evening, everybody. On the outset, I would like to thank for this opportunity. Is my screen visible?
No, Ish.
Okay.
Not visible. Yes, now it is visible.
Okay.
Yes, go ahead.
Okay. So as soon as this indirect ophthalmoscopy historical point of view has started, there is a paradigm shift from for the dilated fundus examination of the detailed fundus examination. Basic advantages to be start with the cost. Obviously, the indirect ophthalmoscopy and the other higher end ultra wide field imaging machines cost is needless to say the cost difference between both of them. And as highlighted, the stereoscopic and in-depth view of the indirect ophthalmoscopy can't match. One of the main feature which was not discussed, I think, was the true color of the indirect ophthalmoscopy, which cannot match the higher end machine, even if it is now whatever amount of upgradation is there. And the field of view, of course, it is 360-degree by asking the patient to steering his gaze, and which is helped by the different types of lenses, and it covers about 60 to 69 degrees of in the primary gaze, while the higher end ultra wide field imaging machines, as we have discussed, it ranges between 55 to maximum 200 degrees. So the other advantage is the topographic measurement of any lesion, which is more accurate as compared to imaging, as eye imaging is in two-dimensional view. And the second thing is the dynamic testing of the peripheral lesion with the scleral depression, which cannot be matched with the imaging any facility. So coming to the literature, those are the lacunae in the higher end machines also, which has the lower sensitivity to the inferior and sometimes the superior sectors also, because of the eyelashes, and the imaging modality low to moderate sensitive for the lesions anterior to the equator as compared to the IDO. So the ultrawide field imaging sensitivity to detect lesions posterior to equator is 74% and anterior to equator is 45%. And there are the more chances of missed anterior retinal breaks in ultrawide field imaging as compared to the dilated fundus examination. So the retinal tears occurs mostly at the posterior edge of the vitreous, which is at the anterior to equator. And to be a good screening test, we have to be a good sensitivity for this. And the ultrawide field imaging, as we discussed, and to the extent to the newer imaging modality also has the poor sensitivity towards the lesions anterior to the equators, and which is attributed because of the low resolution and the low contrast. And the low contrast is partly attributed because of the pseudo color of these machines. Pseudo color means these the color is match up with the blue, with the green and red actually. The other studies which has been shown in the ROP also, that the wide field imaging should be regarded as an adjunct, not as the replacement for the binocular indirect ophthalmoscopy. And the media haze, when the media is hazy like in cataract or in most of the time the floaters, the indirect allows the efficient identification of the retinal breaks. So in all the study, we compared the indirect ophthalmoscopy has shown the gold standard of the modality to examine. So now the few indirect video indirect ophthalmoscopy examples are there. This is the dynamic ophthalmoscopy, in which sometimes the flap of the retinal tear is just opposed to the break, and in sometimes the still photography or higher end machines cannot detect, while the dynamic depression, scleral depression of the periphery can really make the difference and show clear-cut the lesions. These are all the anterior lesions which have, as we can see, a good contrast and a good visualization, which are all anterior to the equator by scleral indentation. And this scenario in which the exudative RDV have to elicit the shifting fluid in supine and in the sitting position, which cannot be matched in the wide field imaging. So the indirect ophthalmoscopy is the only resort, I would say, for the eliciting of this shifting fluid. These are other examples of the retinal detachment with the peripheral retinal breaks. And when it is combined with the choroidal detachment, it is really helpful to know the extent and the type of choroidal detachments also. This is the serous choroidal detachment of the periphery in the chronic retinal detachment. As we can see, the floaters, most commonly asteroid hyalosis. Venous pulsation is another in this video, which we can appreciate. The other forms of like the emulsified silicone oil bubbles sitting in the periphery, and floaters due to vitritis, vit haze. The other peripheral lesions which are really benign, like white without pressure, and can be easily misunderstood in ultrawide field imaging because of the poor contrast and the resolution. The paving stone degeneration is another benign chorioretinal atrophic peripheral lesions which should be observed, not to be treated. And the pigmented lattice degeneration, which in fact, depending upon the situation and symptoms, should be treated. As we discussed the stereoscopic view, the elevated disc edema in this case, we can appreciate which, and the level of the retinal hemorrhages, the subretinal and the vitreous hemorrhages, the floaters because of these conditions, and the fresh retinal detachment with a operculated break along with the vitreous hemorrhage inferiorly. The one of the most interesting part is the lesions anterior to the aura, which is the pars plana cyst. This is a fluid-filled sac space. It's a benign lesion, but in still photography can mismatch or misjudged with an HST. So this was an interesting scenario in which the first post-operative day intravitreal Ozurdex developed a hypotony. We was trying to report the case by capturing the images, and these both are the images of the Clarus and the Optos. But because of the uveitic eye and the syneresis, the vitreous was really liquefied, and that's why the hypotony also developed. And the implant in the sitting position when the fundus was captured, the implant was settling down towards aura, but indirect ophthalmoscopy can detect that implant. But unfortunately, I don't have the indirect video for that implant. But the point to show here is that all the higher end machines cannot reach to the anterior to the equator to depict the implant here. So this was a case, evidence-based case. So finally, dilated fundus examination is must for triaging patients in floaters and to differentiate between benign and treatable anterior lesions. Once the triaging has been done, I feel that the patients can be followed up with the higher and ultra wide field imaging. And to highlight, the low contrast resolution and poor sensitivity to the anterior lesion makes imaging modality less favorable. I thank you.
Thank you, Ish. You have very succinctly put across the positive points of indirect ophthalmoscopy. My perception is that most of the times, the wide field imaging is used mostly by the anterior segment surgeons or non-retina persons to screen the patients. But most of the retina surgeons, they still rely on indirect ophthalmoscopy with depression to screen for floaters and to look at the peripheral retinal breaks. But I would like to ask each of the panelists about their views, whether they would, they depend on the wide field imaging or they would like to do indirect ophthalmoscopy. And then I would request our chairman, Dr. Lingam Gopal, to give the concluding verdict.
You would like me to talk first or last?
Sir, last. Let us hear everybody what all they think. Yes, yeah, we know.
I think both the talks were very nicely presented. They summarized and I agree with you that most of the retina specialists will still go with the dilated fundus examination, while anterior segment surgeons may resort to optos and wide field imaging. One thing is very important that as I mentioned previously also, a good history and general examination of the patient will give you a very good idea as to what the patient has. And I think that will give us a clue. And even if you are experienced, you can say retina specialist, there would be many scenarios where it may be relatively difficult to interpret the optos images because you don't have the advantage of color, you don't have the advantage of depth. But those are the obvious advantages which we get in indirect ophthalmoscopy. So any given day, I am the patient or the doctor, I would prefer a dilated fundus examination rather than optos.
So one
Dhanasri,
strike
can I
was
make a
better.
comment?
Yeah. Yes, please.
Dhanasri, can I make a comment?
Yes, sir. Go ahead, please.
So I've done vitreoretinal fellowship, not that the reason, but I feel more comfortable seeing a patient complaining of floaters to rule out that pars-plana exudates or snow banking by doing an indirect ophthalmoscopy. I do some very small children where I'm not able to do that properly. I get an optos done, and or a case where I'm suspecting strongly acute retinal necrosis at a small foci, I get an optos done, but I still rely on Indian ophthalmoscope with scleral depression, because the pseudo color is annoys me so much, and the small exudates, like the tiny exudates, which can be missed by, which cannot be very well seen by optos. So I still do that Indian ophthalmoscopy and scleral depression in majority of my cases.
So
Very well.
same here. Same here. There's a no-brainer actually. Any ophthalm, I mean, retina specialist will prefer to go ahead with the indirect ophthalmoscopy. Only indication will be like a very uncooperative patient because of pain or photophobia or because of the age-related uncooperativeness. And in small people where you cannot do a decent for indirect ophthalmoscopy. Those are the cases where I would prefer to do a wide field imaging. Otherwise, the gold standard is indirect.
And my take also is the same, ma'am. It will be just be kept as a screening tool in a very busy practices. But I will sleep peacefully only when I have physically seen everything and I am comfortable that I have seen everything and not rely on wide field imaging.
Professor Stewart.
So I think that both you and Dr. Vino summarized this very nicely by saying that anterior segment surgeons very frequently use the Optos as their fundus exam of choice in an eye with floaters, but not a bad vitreous hemorrhage or real bad posterior vitreous detachment symptoms, whereas the retina surgeons will typically do dilation and scleral depression. What that does in the eyes of the law is it sets two standards of care. And so the standard of care for anterior segment surgeons is different from that of retina surgeons. Now we can debate which is the better way to do it. And quite frankly, what I do both. And because when I'm doing my indirect, I want to concentrate anterior to the equator. I don't want to have to keep moving around and looking back towards the arcades. So I get my Optos to give me up to close to the equator, and then my indirect ophthalmoscopy gets me anterior to that. So I agree with both of those.
Gagan, you have any further views? And Vineet?
As an anterior segment, sorry,
Yeah.
Gagan.
No, please.
So as an anterior segment surgeon, I have one question: which wide field would you advise? So an Optos or the Nidec, or which one of?
So
think
whichever is
the-
available actually. Go ahead. Yes, Vinod. What would you advise?
I think that's a very important question. So when Dr. Ramesh described what is wide field imaging, I think nowadays we have a consensus of definition. So anything which includes all four vertex vein ampullae in a single click, that is what we define as ultra wide field imaging. Now, unfortunately, neither Claris nor Mirante falls in that particular definition. So you can do a steered image, make a montage, and you can image you can image all the vortex vein ampullae and more anterior to it also. But neither Mirante nor Zeiss Claris does that. That is to capture all four ampullae in a single click. So Optos is the only one. When we talk about Optos is very good for showing nasal and temporal periphery. But unfortunately, for superior and inferior, it is not that good. So if you are suspecting pathology to be superior and inferior, then it is best to use Optos with steered images. But again, this steer images may not be very good, especially if we are doing it with small pupil. So ultimately, you have to dilate the pupil, and for obtaining these steered images, you have to dilate the pupil even with Optos.
So I think we are lucky to be in a retina institute where we had to learn indirect ophthalmoscope even as postgraduates. So that's why we are lucky that we do indirect, but as anterior segment surgeons, we may not be as thorough or depress as much as you all do it. So I think probably if we think there are certain more things or for documentation, add on to an Optos, but we still need to do a indirect ophthalmoscopy for every patient.
Yes,
I think,
Gagan, please.
yeah, ma'am. So I think Dr. Vinod and everybody covered everything. I think I've had the privilege of using all the wide field imaging tools, and I do believe that, even with the best technician, the best hands, wide field imaging is not a single click machine. And you need a lot of practice on that to kind of really pick up all the lesions. And so I think as far as retina practice is concerned, definitely indirect is the best. But because this is an AIOS webinar and we have a multitude of people probably seeing this, which I don't know, but on YouTube also. So I think one message is very clear that even if it is used as a screening tool, it is not a replacement for an indirect ophthalmoscopy for sure, especially in cataract patients, because even with an optos, you would have a lot of artifacts and everything, which would not be, which can be missed by any technician or even the best of retina surgeons. So I think yes, I think it's probably just an adjuvant, but not a replacement. I think that's very clear. Even with True Color with California, I don't think it's a replacement. Yeah.
So, despite a very good pitch by Ramesh, still all the strikes are for indirect ophthalmoscopy. So, sir, Dr. LG, sir, your verdict, please.
I think we have built our practices based on technology at that point of time. So just because somebody is good in direct ophthalmoscopy, they cannot say indirect ophthalmoscopy is useless. The same way, if we are good in indirect ophthalmoscopy, that doesn't mean that the wide field imaging is useless. It is useful. It's as long as you use it in a proper way. What I would put it is, I would put it first, even a retinal surgeon can benefit by having a picture in front of him, so he knows which area to concentrate upon. Don't rely entirely upon the information given by the wide field image, but accept that you understand that because in a fraction of a second, you have a picture of the entire retina, especially in a person who may not be allowing you to indent everywhere, examine carefully. So once you have a wide field image, then you know which area to concentrate upon. Then you go back to your BIO. I'm not saying that this is a replacement for that, not at all. That can be a really good starting point for many patients with floaters. So you know which area to concentrate upon. So I would agree with what Dr. Stewart said and what Dr. Gagan said, that yes, it's an addendum, a tool, which should be used even by retinal surgeons, if you ask me. It saves a lot of time and energy instead of trying to locate every corner of the fundus where there may not be any problem, you know where to concentrate upon. Thank you.
Thank you, sir. That's a very well taken, a very good message that you have given. So that brings us to another controversial and debatable point in this floaters, that is vitrectomy for floaters. And it's my pleasure to invite Professor Stewart now to give his talk on vitrectomy for floaters.
All right. Well, Dr. Dhanashree, thank you very much for inviting me. It's always my pleasure to interact with my Indian colleagues. Let me go back here. There we go. So thank you for this talk on vitrectomy for floaters. Whatever, we've over the course of the last hour and a half, we've covered very nicely a lot of the secondary causes, uveitis, tumors, diabetes. What I'm doing is I'm going to cover the aging effects of the vitreous. And are we talking about aging floaters, vitreous detachment, without a significant secondary cause? Here are my disclosures. None of these are pertinent to this talk. Now, I was trained by very competent, very conservative retina surgeons, and none of them would have ever considered doing vitrectomy for symptomatic floaters. But the first patient that really convinced me otherwise was this one. This was a 48-year-old gentleman who was a FedEx pilot, complained of floaters. And when I asked him, how bad are they? He said, I've had to abort night landings because the floaters moved into my line of sight. And that caught my attention. And so I listened to him some more. He was very credible with his description, and I talked to him about 48 years old. You're on the cusp of getting a cataract with vitrectomy, but the only way to alleviate your symptoms is vitrectomy. So we did a vitrectomy, obviously straightforward, and he did very well, and his symptoms went away. And so both of us were very happy. And that started me thinking that vitrectomy can be a broader tool than what we're currently using them. Sometimes vitrectomies will truly cause, or these floaters will truly cause decreased visual acuity. Here was a recent case of a 73-year-old lady, bilaterally pseudophakic. She developed significant blurring of vision immediately after her cataract surgery in the right eye. Left eye had bad floaters, not as bad, but the right eye was 20/70. We refracted her twice, couldn't make her better. She had a rent interposterior capsule with a stable central posterior chamber lens, but she had vitreous coming completely into her anterior chamber, filling up the anterior chamber. The view of the back of the eye, as you can see here, was not too bad. There is a little bit of shadowing if you look just in the superior fovea, but it wasn't bad enough that I could be convinced in my own mind that this was 20/70. But her story was so good, And the pathology was so remarkable that I went ahead and did the vitrectomy on her. And first day, she was 20/30. Second day, 20/25. First week, she was ecstatic. She said it was great. Let's do the other eye. And here you can see the other eye. If anything, the imaging of the posterior segment is actually more remarkable in the left than it was in the right, but there was no vitreous in the anterior chamber. Now, as a rule, when I do vitrectomy for symptomatic floaters, I never sign up patients for both eyes at the same time, never. But what I will do is if they come back within a week and they just are ecstatic and say it's all gone, it's definitive, then I'll go ahead and do the second eye quickly, but I won't do it, sign them up and do sequential surgeries without seeing a positive effect on the first eye. This lady had her one-day surgery. All of her symptoms were gone in the left eye, 20/25, very happy. The other thing that really changed my mind on this was this editorial by Travis Meredith, and he was the head of the retina service at Emory when I was there as a resident. He subsequently became the chairman at University of North Carolina, Chapel Hill. He developed a vitreous detachment in 1996, and he wrote this editorial, and it's an AJO. I would suggest most of you read this. It's very insightful, the way he describes this floating material, an oily appearance that you almost feel the stickiness that it's there. And he didn't go on to suggest vitrectomy, but he certainly said at the bottom, can produce such major changes in the way we perceive our world. Well, if you go throughout the United States, you find lots of very interesting characters who go ahead and treat floaters. Here is the floater doctor. None of us are, but this is the floater doctor out of Dallas, Fort Worth, Texas. He's an anterior segment surgeon, and he will go ahead and he'll try any number of things. When you go onto his website, he even does mild pupillary dilation. He does laser. He gives this stuff. I don't know what this is. This is hyaluronic acid drops. I guess this is a way of making money in the clinic, but I can't imagine this reconstitutes the lost hyaluronic acid in the vitreous. But these are the types of things he does. So the treatment of floaters has become a big cash business in the United States. If you do vitrectomy for floaters on Google, you end up with a never-ending sequence of descriptions and practices that go ahead and recommend treatments for floaters. And even in my backyard in metropolitan Jacksonville, I have a eye clinic where they offer advanced technology, namely they do laser for the floaters. And this is done by a medical retina specialist who goes ahead and does vitrectomy. So they're advertising locally. If you didn't know, there's an International Ophthalmic Floater Society, and they have meetings. What's interesting is most of the people within the society are anterior segment surgeons. And so I don't know how many of them actually do vitrectomies, but most of them are anterior segment surgeons. And so their treatment is mostly focused on laser floaters for laser vitreolysis. Well, does that work? Does laser vitreolysis work? Well, this was probably the best study by Chirag Shah and Jeff Heyer, two very good vitreoretinal surgeons in Boston. They did a prospective randomized study, and they found a p-value of 0.09. So it was a trend towards that works to alleviate symptoms, but it wasn't statistically significant. What was interesting out of this was that 50% felt their symptoms were better. We can certainly do a lot better when we put our minds to it with surgery. 3 had retinal tears, and that's a 6% incidence. That's quite high. Even with our vitrectomies, we're not getting 6% incidence of retinal tears. And so they reported this, but even I don't think they feel this is necessarily the best treatment for floaters. We do know that floaters and vitreous detachment can cause significant changes in the vision. And Jerry Sabag, he is the senior author on this, has devoted 30 years to the study of the vitreous, and it's really coming to fruition. They found degraded contrast sensitivity following posterior vitreous detachment. And this is significant. You can see sometimes you just look at the OCT in the lower left, and you can see the shadowing effect on the surface of the retina. And if you do a dynamic OCT in your office, you can see the them moving around with eye movement. And those are the ones that then give you more objective evidence that the vitreous is truly a problem. Well, we've always thought that the ultrasound was the best way to actually make a diagnosis of vitreous detachment. To this day, it probably still is, but it's also a good way of quantifying what the floaters are inside the eye. And for those who do this and are really good with B scans, we can determine which are probably symptomatic vitreous detachments and which aren't by doing quantification of B scan analysis within the eye. So what sort of results do we have with vitrectomies? Well, here was a study out of Eastern Virginia, and they did a retrospective study of patients who underwent pars plana vitrectomy. Their results, if you look at the first bullet point, 100% of patients noted subjective improvement following floaterectomy. Now, when I'm talking to patients in advance, I say to them, in medicine, you never say never and you never say always. But getting rid of symptomatic floaters is as close to 100% always as I think we will ever come in the treatment of vitreoretinal diseases. The important thing is recognizing that that's what the patient's symptoms are. So here was a study out of Birmingham, Alabama. 100 consecutive cases, 70 of which were symptomatic. 15 underwent combined vitrectomy and cataract extraction, and 13 others underwent surgery within 2 years. So the majority of the patients who were left phakic required surgery within 2 years. And they found that the risks in these patients are very small. There is a similar risk to cataract extraction, but the risks of bad outcomes are similar to the cataract extraction. And so they posit that this is by and large a very safe procedure. Gaurav Shah and his colleagues did an iris registry study of 28,000 patients in the Academy's iris registry. They found the results here that were actually kind of shocking. When you look at the adverse results of vitrectomies for floaters, 3.6% incidence of retinal detachment. That's very high. 1.6 incidence of endophthalmitis. That is worrisome. And so they don't have any data to say who did this. Their belief was but 20% of these patients were anterior segment surgeons who may not quite have the facility or the experience as a vitreoretinal surgeon in going back and cleaning out the vitreous in a safe manner. They did not know whether these patients had previous posterior vitreous detachments or not, so we don't know what the consequences of the surgery, nor do we know exactly what was done other than vitrectomy itself. Well, there are two things that come up that should be worrisome signs if you're considering a vitrectomy in a patient. And the things are, one, is the patient phakic or aphakic or pseudophakic? Secondly, does the patient have a pre-existing vitreous detachment or not? And the reasons those are important is that if the patient is phakic, then as I showed you with the study out of Birmingham, there's probably a 63 up to 80% chance that that patient's going to require cataract surgery within 2 years unless it is done at the same time as the cataract surgery. However, one of the approaches is now to go ahead and do a limited posterior vitrectomy. Try to leave as much vitreous between the vitreous cavity and the lens as possible. And the reason for that is we believe cataracts form because of oxygen toxicity in the eye. We facilitate oxygen diffusion from the retina to the cataract, which then is toxic to the epithelial cells within the cataract. Hence, the greater the amount of vitreous you leave in place, the less chance of cataract. Now, having said that, you obviously need to remove the symptomatic floaters. And so if you do that, know where your floaters are and know that you've gotten rid of them, even if you've gone more of a posterior approach. The second thing is reconsider whether or not to do this in patients who have not had vitreous detachments. And if so, are you going to do an induction of a PVD or not? On the one hand, you get rid of all the floaters and the subsequent floaters. On the other hand, you increase the risk of retinal tears and subsequently retinal detachments. If patients don't have a vitreous detachment induced, namely a limited vitrectomy, then they do have about a 14% chance of having recurrent floaters over the course of about 2 years. Whereas for those patients who had a complete vitrectomy, essentially no eyes, developed new floaters over time. Now, that's a tough discussion with patients. You can say, I'll do it the safe way, but you've got a 14% chance that we may have to do this surgery again within 2 years, or I can take a little bit higher risk of retinal tear or subsequent detachment, but I'm pretty sure I can get all your floaters and they will stay away forever. That's a conversation that's important to have with the patients. Well, of course, a Cochrane database study was looked at and trying to determine is either laser vitreolysis or vitrectomy truly beneficial for surgery. And the bottom line is they determined most of these were retrospective studies. And when you looked at the controls and the data points, they really could not determine if either is an effective based upon the degree of statistical significance that they require. I think those of us who have done vitrectomy surgeries know that they work and they're very effective when they're done for the right patients at the right time in a very safe manner. They looked at YAG vitreolysis, and once again, currently published is limited to retrospective case scores, and they cannot determine if it is powered sufficiently to actually say that YAG vitreolysis, despite the fact that this is very commonly employed in the US, especially by those physicians that I showed you earlier on in the talk. We don't have good data to show that it's very predictable, at least as predictable as we want. Well, I already talked about B-scan as a way of quantifying floaters. I don't do that. I rely more on the clinical exam and the OCT. I think it's a time-saving factor because B-scans really slow my clinics down. So I tend not to do this, even though it's a good way of finding data to say that it's a significant problem. Reading speed, VFQ-25, I don't do those routinely, but I think that they're very reasonable if one wants to look at this. This is out of Minneapolis, Minnesota, and they found that vitrectomy improves reading speed by about 21 letters per minute, or approximately 15%. So it's not insignificant in terms of the quality it has, the impact on patients' actions and lifestyle. This slide really surprised me because we're looking at the cost effectiveness of vitrectomy. And I ask you to look at the conclusions on the upper right, and especially the second bullet point. It's cost effective at $1,500 per quality, whereas it's superior to cataract surgery and retinal detachment surgery. I think prior to this, if we had been asked, is this a bigger life changer per dollar than cataract surgery or retina surgery? None of us would have believed that. But this was done by a very good group. Gary Brown, who has really been the guru of all of cost effectiveness data in the US, was one of the significant authors on this. So this data does make actual sense. Question ultimately, to treat or not to treat, know your patients. Talk to them. Make sure that what they're telling you is consistent with floaters or at least vitreous detachment, because they can have this oily appearance that doesn't show always as floaters per se. And also from your side, look at them carefully. Slit lamp examination with 78 diopter lens. Also look right behind their implant. Find out, is there a big floater sitting there right where the node, or refraction of the eye. And then look at the OCT. Is there shadowing on the OCT? Exclusion criteria, never jump to surgery immediately. I always have patients come back a second time because I want them to tell me that this is not getting better. And if patient has an acute vitreous detachment with no hemorrhage, I will say, and they're really bothered by the floaters, I'll say, I will not even entertain surgery within 6 months. And you come back and talk to me in 6 months. If it's still there, we can go ahead and do it. But since most of these patients symptomatically improve, I'll give it time to make sure that they're convinced that this is not a problem that's going to go away. So in conclusion, the vitrectomy is increasingly accepted for the removal of symptomatic floaters. And with careful technique, the complication rates are low. Cataract development can be lower than expected if we do a limited posterior vitrectomy rather than a complete vitrectomy. YAG vitreolysis may help some patients, but probably it's 50% effective and not likely more than that. And the analysis suggests that vitrectomy is highly, and I put in parentheses, surprisingly cost effective. So thank you very much. Thank you for inviting me. Always a pleasure to speak to this audience.
Thank you very much, Professor Stewart. That was an excellent talk, and you really covered the entire gamut of pros and cons for vitrectomy for floaters. So, I definitely agree with you. I mean, considering the cost and as well as the side effects of vitrectomy, I mean, it should not be taken lightly and should not be advised lightly, unless the patient is highly motivated and definitely asks for the vitrectomy. I would not rather do vitrectomy. There are many patients whom you will advise surgery and they will say, no, but it's okay. It goes and comes and goes. It's not really troubling me and it's okay. I will live with it and all. So these patients are definitely not candidates for vitrectomy because they may not be happy even after vitrectomy.
What I often say to patients is, I can say that you could have the surgery done, but you have to talk me into it. So very much like you just said, they have to be the ones to push for it.
Correct. Right. So there's just one single patient I remember, which Vineet mentioned, who was really very much bothered with the floaters, and with vitrectomy for floaters, he's the one who was really very happy, and so that one patient is there. So some of these patients they do benefit, and as you mentioned, you have to look at the indications, correct indications, and again the another point which you mentioned very clearly is how much vitrectomy should be done. Whether you should be really very aggressive or whether you should just clear the floater and leave the rest. So that was also a very good point that you mentioned. So we have only about 5 minutes more to discuss, and maybe I will ask Dr. Lingam Gopal to discuss on this and give his concluding remarks.
I would like to thank Dr. Dhanashree for giving me this opportunity to conclude on this excellent talks, which were on vitreous floaters. Regarding the last talk, I have basically a few comments. I think the kind of population you deal with could be totally different in the United States versus India versus some other country. So I find, for example, in my own practice that the number of patients who come with a truly floater-causing floaters are very few. There are a lot of patients who are very bothered by even that small thread-like floaters. They complain of floaters, but you don't see any floaters in their eye. And those days obviously is out of question for surgery. And those patients where you see thick floaters in the vitreous cavity are very often not good candidates for surgery because they're high myopes with abnormal vitreous attachments where you know that the risk of vitrectomy is outweigh the risk of the benefit of removing the floater. So is the normal PVD a floater which is bothersome? As Professor Stewart said, you leave them around for 2-3 months, they get used to it. I got used to it. I had PVD in both eyes. It doesn't interfere with my vitreous surgery at all, even ILM feeling. So I know that PVD induced floater can be easily adjusted too. It's not a problem at all. But if the person is so anxious and feels it is affecting them, doing the removal of the PVD is very difficult. But what I'm trying to say is that it's totally surgeon-oriented and patient-oriented decision, and because of the type of population you deal with. Now, to summarize about the whole presentation, I thought instead of repeating what everybody has said, let me conclude by saying that one, floaters from the patient's perspective are different from the surgeon's perspective. If somebody comes with a little bit of vitreous hemorrhage and you examine the fundus and everything is normal, you say, okay, this is probably posterior PVD, induced vitreous hemorrhage, there's no retinal break, you're absolutely okay, you're all right. But the patient is not going to be all right mentally until the hemorrhage goes away. So we should understand that logic of patient's symptoms also going away before we explain to them that it's a relatively benign problem. And we also know that vitreous floaters are heterogeneous. The causes are heterogeneous, and hence no single rule will apply for all the reasons for floaters. So the associated symptoms and the circumstantial evidence would guide us into knowing what we are dealing with. So the background information is what will allow us to triage the case into the correct slot. So young age, you think more of inflammation as an important cause of a floater. A high myope coming with an acute onset floaters, obviously you look for retinal breaks, etc. But somebody with chronic floaters saying for the last 2-3 years have been bothering him, coming in and out of the field, it's probably more of vitreous condensation. Post-cataract surgery, it may not be a true post-cataract surgery PVD occurring. It could have been there, but probably not obvious to the patient because of the dense cataract, which some of them have. And once you remove the cataract, it becomes obvious to them, but not always induced by cataract surgery. Then adult onset, bilateral, simultaneous or sequential, you definitely like to think about PVL and exclude it. Non-diabetic, somebody who has had a laser, it's most likely vitreous hemorrhage. So from knowing the history and the patient's background, you can reasonably conclude upon what you're likely to face when you examine the fundus. An adult, for example, these are odd cases which you should keep in mind. An adult who has had a hospitalization, long hospitalization, intravenous therapy, etc., comes with floaters. Please do look for carefully candida infections in the eye. I have at least 2 patients with endogenous endophthalmitis, nearly manifesting after 25 to 30 days after discharge from a general hospital. So that it grows very slowly depending upon the level of immunity of the patient. But once it comes into the vitreous cavity, it continues to grow, although his general immunity has become better. And hence they become symptomatic much later. So do keep in mind endogenous endophthalmitis in your mind when you see floaters as a presentation in the post-hospitalization stay. In fact, there's one gentleman who developed one single speck of floater lying on the macula and had 6/6 vision for almost 2-3 months. And we did not know what the speck is. On OCT, it was seen, but no vitreous cells. Ultimately, actually proved to be aspergillus. And it grew into a full-blown endophthalmitis nearly 3 months after the single speck fell on the macular area. So do keep in mind that adult onset endogenous endophthalmitis. Now, adult onset acute PVDs, most often they have flashes along with floaters rather than just acute PVD. And when you have hemorrhage plus PVD versus only PVD, your evaluation will be different. It's only PVD, as said, taking a picture and examining once in a while, and not every time, may be okay. But somebody who has a vitreous hemorrhage along with PVD, first time you may not be able to examine the entire retina. Second time again, you have to do a detailed examination after 10 days also when the bed rest hemorrhage settles down. The last but something which we see in India more often than the United States is a floater which is mobile in the sense like a worm in the vitreous cavity, like a cysticercus or a Gnatostoma spinogyrum. The patient actually comes with a positive history that a motile worm and he or she is observing. Last but not the least, are the floaters coming in patients who are anxious relatives of a close relative who developed a retinal detachment. The day you operate upon them and say floaters are important symptoms which can precede the occurrence of retinal detachment, every one of them comes back with floaters. So these are all people who have very, very minimal floaters, which you start imagining when they look at a bright screen or a tube light or a bright sky. So with this, I would end this conclusion. Thank you very much.
Thank you very much, sir, for that excellent summarization and all the good tips that you have given. So I think we have just exceeded our time. I would like to thank Chairperson Dr. Linga Gopal and all the panelists and all the speakers for their excellent contributions. And thank you very much for agreeing for this webinar at such a short notice. I appreciate your participation and your cooperation. I would like to thank Dr. Santosh Honavar and the AIOS for organizing this webinar and for giving me the opportunity to moderate this session. So, and I would like to thank the audience for their participation and for the active listening. Thank you very much. Good night to all. Bye-bye.
You did a wonderful job.
Thank you, sir.
Indeed. Good night.